Welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into my podcast. Today, we're going to get into answering some of your questions that you had regarding our recent series on endometriosis. You got some great questions. There's some good comments in there, and just a few things I want to circle back and kind of be more precise with. As always, it's so important for us to be clear. My goal in this is to be helpful more than anything else. It will always be my goal. And to the degree that I'm helpful is to the degree that I'm doing a good job. Your feedback helps us clarify things and do a good job at it. So thank you for your feedback as we're going through this. Before I get into it, please do me a favor. Just scroll down. You'll see this little section there that says subscribe. So please subscribe. If you like it, press like. And if you want to share it. With that said, let's get started. Endometriosis. It was a good series to do because it's something that I've seen for a long time in practice, and I know there's not a lot of good care out there, not a lot of understanding around it, other than just birth control and surgery. And I know a lot of you fall through the cracks on that, and it doesn't help you. Some of you it does, and some of you reported that it's changed your lives, it saved your lives, that protocol, and I'm so happy that it does. And any type of therapy that we can find that gives you a higher quality of life and preserves fertility in this case, that's all I want. I notice when I post these on here, there'll always be those times you get internet trolls that come on. And you know they're a troll because they don't come on with curiosity. They come on with a deep comment and they just go on more like telling that they're right. And they kind of slam into things and they're more focused on their own vision of what the disorder is, or there's only one therapy that fixes it. And I get that a fair amount. You know, we'll post a reel, or we'll be on YouTube and we'll post a full episode, and you'll have people jump on and they just say, I had to take this wonder tincture by Dr. Sherman, blah, 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 and it saved my life. That's advertising. That's not helping anybody. Other times I'll have someone come on, and the reason why it's advertising is not helping anyone. Dr. Sherman may be a miracle worker, but if we don't know what's in Dr. Sherman's formula, what is it? It's important that when we share information that you can replicate and it will work for you. It doesn't require you having to buy it from Dr. Sherman. It's important that when we share information, the information we share is not based upon profiteering of an individual, either financially or for their ego. One of the things I've gotten a fair amount on this, and anytime I talk about endometriosis, is a lot of people go crazy over the source of endometriosis. Where does it come from? It's not from the uterine lining. And they'll say these deep things. And where it becomes a concern is that they're no longer coming at it from, this is where I have learned this. They're not saying endometriosis is not from the uterine lining. It's uterine similar. There's similarities with the uterine lining that they share, but it's throughout the body. They don't share their research. They come into it immediately disparaging the topic and what I'm citing, the research I'm citing. They don't even speak to the research I'm citing, but they're just immediately disparaging. And why I'm spending time on this is because I want you to understand the internet is full of this. I'm always willing and happy to see where I've come short so that I can learn more. I've learned to be good at that because I go into the room more curious now than ever before. As I get older, I get more and more curious and less closed-minded. I become more and more open-minded. I think that's a better way of progressing as a physician, as a care provider. So when I read through the comments and I see those, I try and understand the science that drives them. But if they don't cite the research, I don't know where to even begin with it. I want you to know that everything that I comment to, everything that I speak to, everything that I promote, that I talk to, I cite my research thoroughly. I spend a lot of time with these episodes because I want to be helpful to you. And I also want to make sure that you know where I'm coming from, because I believe that if you understand how I got to this place, it's easier for you to understand how it's effective, and it's easier for you to adopt it also. So that said, I'll move into now answering some of the questions that are posted. An important question was brought up is why does synthetic birth control make symptoms of endometriosis worse? Brilliant question. Frustrating question. Dispelled often by care providers because it doesn't make sense to them. And let me walk you through why. When we give someone synthetic contraceptives as a means to suppress her hormones, when we're giving you synthetic, estrogen, synthetic progesterone, our goal is to suppress your natural production of those hormones, just bring them down to zero. The reason why they do this is because when your hormones are completely out of balance, and it's just cheap and easy just to push you onto something that's just going to regulate it. You take the pill once a day, and that basically puts it all down. It works often, but not always. Why they believe it will work is because through full suppression, you shouldn't have these excesses of estrogen. And synthetic progesterone is known to inhibit endometrial hyperplasia, which is thickening the endometrial lining. So why wouldn't it work? The thing about endometriosis is a little more complicated than just growing tissue or not growing tissue. It's more complicated than just estrogen. And as we mentioned in previous episodes where we did the series, there's a lot of inflammation involved. Synthetic progesterone that's found in oral contraceptives really is an inflammatory complex. And why I'm saying that is women on oral contraceptives tend to have a higher levels of C-reactive protein, inflammatory chemical in their body. So sometimes you don't feel better on oral contraceptives with endometriosis because the inflammation was not addressed. And you may have inflammation already in your lifestyle. Your diet may have, synthetics in there. A lot of times we really eat a really processed diet that leads to more inflammation in the body. If you don't have a lot of antioxidants in your diet, there's a lot of things that would trigger you to be more inflammatory. It could also be you're eating foods you're sensitive to. Lifestyle, there's a lot of ways our bodies create too much inflammation. So if you take oral contraceptives, you tend to have more inflammation in your body. Together, you're not going to have very much symptom relief. What else? The big part of that series we did that I think is the most important takeaway on here is that the monoamine pathway, which is when you take tryptophan in your diet, the amino acid tryptophan, and you work it all the way down the line to serotonin, then melatonin, because that's what it does. When you take in tryptophan in your diet, it moves down this metabolic pathway. It will make your serotonin, which is your natural antidepressant, and it's going to make melatonin, which is your pro-sleep neurosteroid. They do more than that, though. That monoamine pathway in endometriosis is really underrepresented in medicine. It is incredibly important. And we know that when women have higher levels of melatonin, when we give them melatonin with endometriosis, it is really a game changer. It really is a huge game changer. So how does this play into the oral contraceptive question? When you take a synthetic birth control, when you take synthetic progesterone, that's synthetic progesterone, progestin, or medroxyprogesterone acetate, whichever version they're giving you, that synthetic progesterone does not help you in the production of serotonin and melatonin. If anything, it gets in the way of it. Progesterone, bioidentical, natural progesterone that you make, or if your doctor prescribes bioidentical progesterone, that enhances the pathway of tryptophan, making serotonin, making melatonin. This is the same reason why some women on oral contraceptives are going to have more symptoms of depression or PMS symptoms because the synthetic progesterone, they're not getting serotonin, they're not getting melatonin, they're not doing well. Bioidentical progesterone, they're going to get the serotonin, they're going to get the melatonin, they're doing well. We know that with endometriosis, if I give you synthetic birth control, and your endometriosis is really impacted by that melatonin deficiency because melatonin, again, plays a huge role. It's not just sleep. Melatonin plays a big role in endometrial health and the endometriosis. And we know that women have that progesterone level, that melatonin levels being a little bit higher. Melatonin is an antioxidant, helps with inflammation at the site. Melatonin plays a role with the migration of endometrial tissue. It's a very important part of this. So if you're on oral contraceptives, it will make it worse. Bioidentical progesterone will help. And also we would use melatonin. Melatonin is really important. There's a question that came up that is not just specific to endometriosis, but just to all women in general. I want to make sure I'm really good about answering this. Do you need progesterone if you don't have a uterus? If you've had a hysterectomy, do you need progesterone? Absolutely. Absolutely. You are more than the sum of your uterus. You really are. Progesterone is not just for the lining of the uterus. Progesterone for breast health, critical. Progesterone for neurotransmitters, critical. Progesterone for immune modulation, also important. It's big. So do you need progesterone without a uterus? Yes. And we do prescribe women who've had hysterectomy, we do prescribe them progesterone. It is helpful. Symptoms are resolved in many cases, and we also see benefit in the lab work. This is a good question. No one ever asks, but it's a good question. And it's the most logical question that I've never been asked. It's just like, if it's a logical question, I've probably gotten asked already. You know what I mean? Because you guys are smart. You know what I mean? But the question was, can I take progesterone with an SSRI? And that's a great question, because I keep talking about how progesterone affects your ability to make serotonin and melatonin. So then there should be, well, if you're affecting it with progesterone, is it bad to take an SSRI as well? Yes, you can take both. They are not exclusive of one another. They're not going to directly inhibit one another. Just think of it like this. I want to bring your progesterone to where it should be as a woman cycling, being healthy. We want ideal levels of progesterone in your body. If I'm not being supra physiological, bringing it up into these really high levels, if I'm keeping it at a normal level and you're just taking your SSRI in there, will they inhibit each other? No. Even if you take high levels of progesterone, is it going to affect the SSRI? No. But we should always know that when it comes to hormones, if I'm keeping you within the normal range, will it impact these pharmaceuticals? Chances are no. Still check with your provider. And you yourself go online. Many of you should do this. I believe you should do this because not every doctor does it. Start plugging in your medications that you're on and see if they react to each other. So say you're on an SSRI like Zoloft and you're taking Prometrium, which is a bioidentical progesterone that you got from your pharmacy. You want to see, do they cross-react? So you do that cross-reaction checker. Those are available online. They're free and useful. But do they react? No, not at all. You're fine doing that. And then how much progesterone is reasonable to take with endometriosis? And the question she asked, was it 0.75 milligrams to 200 milligrams, I think it was, or 100 milligram. If we're using a synthetic, that's when we're talking about 0.75, because it's a different measurement. It's a different type of medication. It's different structure. It doesn't really work similarly. It's similar, but it's not the same. So I'm never using synthetic. I've never prescribed synthetic by itself. I never will. It's very, very rare that I prescribe oral contraceptives. Very rare. So dosing of it, I'm not quite sure off the top of my head. When it comes to bioidentical progesterone, I'm real clear on that one. If you're swallowing it as a capsule that's powdered progesterone inside of it, please know that is one of the lowest absorption rates on that one. So you may need a higher dose. It doesn't mean it's useless. It just means you're not getting the best absorption. If you live in a place that's all you have access to, fine. Take it. We want to get you 200. Then you go to 400, 200 to 500 is a big jump. 200, 400 is a big jump. 200, sorry, go to 200, go to 300, go to 400. Keep increasing until you see the lab move. You want to make sure your lab moves. You want to make sure you're absorbing it. The only way to do that is to test for it. If you're going to do the progesterone, that's in Prometrium, pretty expensive prescription, but that's progesterone that's in a gel cap. The progesterone is suspended in oil. It's peanut oil. Some of us have problems with peanut oil. I know. And so we don't always prescribe it for that reason. Also, it's very expensive and insurance doesn't like to cover it. But that has a pretty good absorption rate. Start at 100 milligrams, same thing as the powdered. You slowly increase it till you see you hit the right level. The one that I use the most in my practice is the one that dissolves sublingually. It's a troche. That one, again, same thing. Start with 100, you slowly work your way up until you see the labs reflect benefit in the patient in front of you. I'm going to close with this. I know I spoke about it a minute ago. I'm going to really be very clear on it. The thing that got the least amount of comments too on the reels and on things is melatonin. Look it up for yourself. Just look up melatonin and endometriosis. Just do your homework on that. You deserve that. Melatonin is very important, and it is a key component of care, I believe, in my practice. I know it is, and I believe it could be very helpful for many people to consider. Lab work, tricky to do. You should do your lab work at night. Not many clinics have labs open at night. There's saliva testing you do to verify. That's possible. However which way we can measure it for you, we will. But at the end of the day, it's over the counter, 5 milligrams. Try it. Check in with your physician. See what they think. But please consider melatonin. Thank you. Thank you for tuning in. Thank you for being a part of this wild ride, this podcast has turned into over the years. Justin and I, we still, we're 2 years in, aren't we? We're coming up on 2 years together. We're still going to keep doing it. It's been one of the most wonderful things that's happened in my life, and I'm so thankful for it. I'm thankful for your participation. And yeah, I'll see you at the next episode.